We've struggled with this concept of what we have a right to, what we have an obligation to do for each other. We have always valued the person who can pull themselves up by their own bootstraps, that entrepreneur who made it big, that person who is that one in a million who says, wow, look at them and the great things that they have done. And we hold people like that up on a pedestal. And so we create this added mindset of you need to do this on your own, that you are responsible for what your health is. You are responsible for what your outcomes are, et cetera. And so a lot of it becomes this issue of saying, it is about you, or it's about me. And sadly, I think that a lot of it boils down to a word that many people won't like to hear, but it's a selfishness. If me and mine are taken care of, that's it. You and yours, that's your problem. That's your problem. And most countries don't look at it that way. The countries that have better healthcare outcomes at lower costs, primary care base, et cetera, say, we're all in this together.
Primary care is where you go for your preventative and routine care, and it is also where you go to have all of your specialty care coordinated.
Primary care is delivered by someone who has training to be able to take care of the undifferentiated problem, by which I mean a patient of any age who presents with a symptom. And that symptom can be in any organ system, in any body part, psychological, social. Primary care addresses that problem and most of the time settles it.
So when you're talking about primary care, your old saying, if mama's not healthy, nobody's healthy. Getting healthy so you can take care of your family. Getting healthy so that the workforce, the economic impact of healthy people being in the workforce lifts the entire community.
My name is Brittany Schaefer, and I'm a fourth-year medical student here at Florida State University College of Medicine. My mom's a pediatrician, and so she spoke all about her patients when I was little to growing up, and so I always thought I would do pediatrics and work with kids only. And so I went last year for my third year of medical school for one of my rotations in Marianna, so I got to see patients from the beginning of June to the end of April. And saw them multiple times across multiple different hospitalizations and just for their well care, everything in between. And I realized I liked working with old men patients as well as kids more than anybody else. Those were the populations I liked the best, and realized maybe family medicine was a really good fit for me.
My name is Kristen McGreeny. I am a fourth-year medical student here at Florida State University College of Medicine. Not only do I come from a medical family with both my parents, my mom's mom was a doctor in the Philippines, and she was a primary care doctor. She had a long-going relationship with her patients. These patients she would see throughout their lives. You know, when they would say, this is my doctor is this person, it was her. And that really resonated with me, making those long-term connections, really advocating for your patient over time. It was really what got me interested in primary care. It was really kind of the exact opposite of, you know, they come in, you see your patient for one time and then you don't see them again.
In the first couple of years of the College of Medicine, the original founders thought that they could hire enough clinician teachers that all that these doctors would do would be to teach clinical medicine to the students. That we'd have a group of 15 to 20 docs, and that would be their job, is to teach the students. Within the first couple of years, that quickly got moved aside to the idea that if they're going to be clinicians and teaching students, they need to also be active in seeing patients. I'm a family doc, it's my identity. I talk about how seeing patients feeds my soul. I don't want to stop doing that. Additionally, I believe that I will lose clinical relevance. Fortunately, Madison County Health Department contacted the College of Medicine, says, we're desperate, do you have any primary care docs that can help us out? We've lost our nurse practitioner, we've got these patients that need care, and it was serendipitous. I said, yep, sign me up, I'm ready to go. From that and a number of other agreements, the various docs within my department, within clinical sciences said, yes, we need to start getting active, geriatrics as well. And so that led to these wide ranges of agreements. Myself out of the Madison County Health Department, other faculty at Student Health Services, other faculty at Bond and Neighborhood Medical Centers, the two federally qualified health centers in the area.
Bond Community Health Center is a federally qualified community health center, or it's known as a FQHC, if you will, which means that we have certain policies and procedures in place that mitigate risk and try to certify that we're good stewards of federal funding or state funding, that we practice comprehensive medicine, that we see patients regardless of their ability to pay.
So the federally qualified health centers of the country are the safety net in the United States. For those folks that don't have insurance, where do you go? A federally qualified health center. So that's a center that receives grant money from the federal government to pay the bills. And there's certain regulations that come with that.
Problems began to show up right from the beginning. Among those problems were doctors weren't really a part of that health system. We were shift workers. Came in, worked for 4 hours a week, worked for 8 hours a week, and then you're gone again. The clinics in which we worked didn't see us as really being a part of them. So the relationships were often strained. The priorities were different. Our priorities were certainly providing high quality of care, but being able to teach students along the way. And many of these facilities were patient volume. Our priority is see more patients. And we would rather you not bring students with you and that you saw 3 more patients every shift rather than bring a student with you and slowing you down that way. They start looking at from just a dollars and cents line, what they had to pay FMPP, what they had to pay the practice plan to buy 4 hours or 8 hours of a doctor's time.
FMPP, or the medical practice plan, is bringing the mission of medical education to life for our community, because it's really taking our faculty and our students out into the community to deliver the services we're trying to teach within the College of Medicine. It was established about 12 years ago as a mechanism to oversee the medical services, the faculty medical services for those clinicians within the College of Medicine who are delivering their services to the community.
I was basically fired. At Madison County Health Department, I was a regular physician there for 10 years. They said, we're not sure what our budget is going to be, and we are under pressure from the state of Florida to stop providing primary care services. Most county health departments have stopped. We keep doing it because we're a critical health shortage area, but we're not sure. I said, well, I hope for the best. I told my patients I'd be here. And in the 10th year, they said that because the way the state of Florida is, the budget is, et cetera, we are simply going to greatly reduce the primary care services that we provide here in Madison County. Thank you very much. We wish you could stay. We love you very much. Your patients love you, but we got to let you go. For a while, have had no regular medical home, no regular medical clinic, which quite literally bothers me on a daily basis. I'm a family doc. I want to see patients. I need to see patients. It left myself and many of my peers with a hole. So we looked all around Tallahassee, looked at a number of different options, and settled on this as really being one of the ideal places. What we found here is this facility, it's going to sit right over there, will be a patient-centered medical home where I can and my colleagues can see patients in the context of this community, providing for the full range of healthcare, preventive care and acute care, and really understand the people, where they're coming from, what their healthcare needs are, and to do what we can to meet those needs.
It's starting out right away, building a business pro forma with the commitment and dedication that we will serve anyone regardless of their source of funding. Because traditionally academic medical centers, the medical practices like ours that are housed inside colleges of medicine, typically they are the ones that will serve the underserved. Private healthcare enterprises are typically not the ones that will provide the safety net for those populations. So academic medical centers often provide the safety net.
Everybody needs a good primary care physician, or what we call now a medical home. That does a variety of things. So first, it gives you entree to the system. so that it's accessible, that when you have a problem, someone's going to see you in a reasonable period of time, and if it's an emergency, someone will see you urgently. Good primary care is also very likely to take care of your problem immediately. So going to the doctor's office is a relatively modest financial event. Going to the emergency room is not a modest financial event. It's a big event.
So we say, well, why are people going to the emergency room to get their care? They don't have time to take from work during the day, but they know that the emergency room is open all night. But the emergency room is also the most expensive place to get care because these are highly qualified people that learn how to deal with trauma and all sorts of other things. And here you are with a sore throat, but you just don't have the time to take from work to go to primary care during the day. So I think systematically we have to look at what's the system that we're providing, what is it that we're offering people to make it easier for people to get preventive care and primary care so it's not as expensive later on.
If we can keep people out of the emergency room who need to really be seen in a primary care setting to take care of preventive medicine and primary care medicine, then it decreases the overall burden in the ER. It is more profitable, if you will, for the hospital to take care of people who need to be hospitalized as opposed to people who are coming in with something that should be handled in the outpatient setting. So the hospital benefits and we benefit. The hospital has many people that come in, they need services, they get discharged, and they don't have a medical home to go to.
We're a direct primary care practice. That's what we do. We take care of patients for a low monthly fee. They get unlimited access with discounts on labs, medication, radiology. We also negotiate rates for eyeglasses and dentists and all kinds of things for our members. We provide excellent care for a low monthly fee, and they don't have to pay copays or anything when they come. Having a medical home allows them to have a relationship, to discover their health issues before it's at an extreme point and they end up in an emergency department and then are routed directly to, a specialist because it's gotten to a place where it's so extreme and so far gone that there's no chance of doing, the steps in the beginning.
Specialty care is more expensive. There's a higher cost with going to specialty care than going to primary care. So that's one reason why we would want to avoid it. We would also want to avoid it because there aren't enough specialty care doctors for the level of need that we have in this country right now. And so we really should take the opportunity to prevent the need for going to specialty care.
And the concept of preventive medicine is still very new to people. A lot of folks come to the doctor like they go to the dentist. They go when something's hurting or when they're sick. But those things such as getting a screening colonoscopy, getting pap smears, getting mammograms, getting prostate evaluation, getting a good cardiac checkup. A lot of these things are preventable, and you decrease the financial burden of health care across the board.
So my particular role as a clinical health psychologist is to work within the primary care setting. And so I specialize in working with individuals who have chronic health conditions who may need to change their behavior in order to improve their condition. So for instance, if you have somebody with diabetes, they really need to be careful about their diet and maintaining a regular exercise routine. Sounds easy, but it becomes difficult to do, especially when you have a debilitating condition if the diabetes is progressing. And so where I come in is in helping the individual change their behavior, maintain their behavior, help them to find the motivation that they need to comply with their medical treatment.
About 50% of the office visits in the United States are done by family doctors. Not a small number. But compared to many other health systems who turn out better outcomes, who have better life expectancy, less infant mortality, those systems have higher percent of primary care physicians than does the United States.
I paid my way through medical school by being in the United States Air Force. So I spent a year in Turkey and 2 years in the United Kingdom. I was in Bedfordshire, and when I would visit the hospital or admit somebody to the hospital from, RAF Chicksands, where I worked, it became really clear to me they're doing this way differently than we do. And it turned out that if you weren't a primary care practitioner, if you wanted to be a specialist, you had to fill one of the allocated, permitted specialist slots. There was a fixed number. So let's say you were a cardiologist. That's great. You're going to be a primary care physician until a cardiologist slot opens up. That will happen when the cardiologist retires, expires, or moves somewhere else. And until that happens, Mr. Cardiologist, you're a primary care physician. I hope you learned a little primary care in your cardiology fellowship. So there was literally a regulatory environment around the number of specialists that were possible. In most other developed nations that have very much lower healthcare expenditures and better health than we do, they have 50% or more of their practitioners are primary care. So at least half. In our country, it's about 30% are primary care. So the data seems to demonstrate or suggest very strongly that countries that have a greater primary care orientation spend less money, but also control illnesses or treat illnesses at an earlier stage in their development. And people enjoy better health than we do in our country at much lower cost.
The way educational training in medicine has evolved in the United States has been directed towards specialty training and subspecialty training. There's been sort of a higher status associated with that, in my opinion, not always appropriate. And there have been increasing inequities in income. Physician incomes have been increasing, but specialty physicians' income have been increasing like this, and primary care income has been increasing like this. And so over time, the gap is widening. And medical students who come out of their training now with an enormous debt, $250,000 of debt, $300,000 of debt. If they say, well, I can do a career where I get paid X, or I can do a career where I get paid 3X, there's an incentive. That's a real life decision that people make. And in this case, it's something of a disincentive to be in primary care.
Right now in the United States, medical school is very expensive. When you're in college, when you're a pre-med, and you're reading things that come out in the newspaper or magazines like, oh, going to medical school is the $1 million mistake, things like that, it is something that weighs on you from the beginning. Your peers, when you're in medical school, are graduating, getting jobs, and they're out making money where you take on this financial responsibility. There are pressures to make back that money that you spend going to school. And here, general practitioners make less than specialties.
So this clinic, meaning the FSU Primary Health Center, is a next step, if you will, in a series of processes that have been going on for the past 5 to 7, 10 years even, where we've been growing what I refer to as our clinical enterprise, which is our clinical services brought out to the community. FSU Primary Health is our first effort at delivering services from infants to older adults in primary care and behavioral health settings.
We need, as a College of Medicine, we've grown to the point where we can and we should start to practice what we teach. So we've been telling our students for a long time about what it means to have a patient-centered medical home and to provide patient-centered care, how to provide evidence-based care, how to reach out and serve communities of greatest need, rural, minority, elderly, and other underserved populations. And we've been doing it in kind of fits and starts and little bits and pieces that way, but we really have not done it as a College of Medicine in any consistent and organized fashion. But this is a physical manifestation, the home for which people will have their medical home, address their ongoing medical needs, acute care needs, in teaching students how we model that care and how we deliver that care. We talked to some of the leaders of the local community clinics to say we think that this may be good. We talked to some of the local medical leadership, the CEOs of the hospital, the head of the Capital Medical Society, and say, we're looking at maybe having a primary care clinic, something to be relatively small. We have no interest in developing some large multi-specialty group with, every kind of subspecialist under the sun. The feedback was, quite frankly, rather positive. There was an increasing awareness of the need for more primary care docs in the area, so we'd hear that from some of the leadership. They say, oh, You need more primary care docs? Yes, we need them. We need them in Tallahassee. We could drop a dozen of them in town tomorrow and we'd find them plenty busy within 6 months. And so we began, exploring, talking to other people, looking at land that we might have, looking at where the funding might come from. We continue to focus primarily in the western part of Tallahassee, where there's not a lot of other healthcare services. We've got to consider issues of what our neighbors are like. People typically won't go way out of their way for healthcare. So one of the places that we looked at, initially temporarily, but started looking better and better, was a piece of property that FSU already owned in southwest Tallahassee. This was the old Florida Highway Patrol building, and FSU was using it for storage space. They stored old library books, etc. there. So he said, oh, this might be a perfect place. It's right in the heart of a neighborhood. It's close to FSU.
We still have a significant number of uninsured people across the state. We don't have enough doctors who are willing to see uninsured patients. The reimbursement rate for even Medicaid is so low that a lot of doctors can't see Medicaid patients. The reimbursement rate for Medicare is so low that a lot of doctors won't see Medicare patients.
Most of our patients receive Medicaid in terms of access to it. There's still, by definition, even if it's a sliding scale, there's a little bit of money that has to be paid by a lot of the adults that come in. And if they don't have that money, that would be a barrier for them getting care.
We don't take insurance, and the reason why is that we feel that insurance oftentimes disrupts the relationship between the patient and their provider, and oftentimes insurance will dictate what can and cannot be done. And also for us on the business side, taking out the insurance piece allows us to keep our overhead low, and so we're not always chasing an insurance company to get reimbursement for services. It's directly, from the patient to the business, and the services provided immediately without delay.
So think about fire insurance, okay? Your goal is to never use it, right? Because if you're using it, it means what happened? You had a bad outcome. Think about life insurance. You're not likely to be around after you use it, right? And so it's about an infrequent event, and it's about pooling the risk related to that infrequent event. Then think about health insurance. You actually want people to use it for some things. You prefer they not use it for others. You hope they use it at a level of frequency that actually relates to good health, rather than thinking about life insurance and fire insurance where you hope it's not used at all. So just the notion that we call it the same thing makes little sense. The idea that we risk pool may or may not actually work, but we've got to figure out a funding mechanism that allows us to deal with people who have much more serious complex diseases, who need more of a service than people who don't use services very often. So it's probably that latter piece that causes us to think about pooling and thinking about insurance. But the whole notion that we call this insurance is perverse to call it that. We really need to think about it another way. Now, I call it assurance, which is we want to assure that people have some basic coverage of health care.
What we think would be ideal is if everyone had a direct primary care for their primary care services, and insurance was used for catastrophic. For example, when you want to change the paint in your car because you don't like red anymore and you want blue, you pay for that. When you need an oil change, you pay for that. When you need new tires, you pay for that. That's what insurance should be. So if you have something catastrophic like an accident, that's when your insurance pays. But for your day-to-day stuff, you manage that on your own. That's how it should be with primary care, to get the insurance companies out of that relationship, and then the insurance company is to help with catastrophic. Same thing with your house. If you decide you want a blue house and you have a yellow house, you paint it blue. You don't call the insurance company and ask them, and they're like, well, actually you need to paint it red, and then we'll decide if that's okay, and if that's not okay, then maybe if you go through an approval process, we'll agree to do it blue, but then you have to actually go through 5 hoops and talk to 7 people, and then maybe somebody will get a blue approved that maybe you like and don't. So that's the problem with the insurance. Insurance submissions are 80-90% primary care. If you get all of that out of the insurance world, 80-90% can be taken care of in a good primary care practice, right? That's what we do. Yes.
And direct primary care is the solution for that. It's transparency, it's simplicity, and it's good for patient and provider and keeps the insurance out of it. Oftentimes in a traditional practice, they are, far behind in getting reimbursements from the insurance companies. And so that puts a burden on the practice, because we don't chase insurance companies. We don't have to staff to do all the billing and all that processing that takes place. And, it's a whole production. And so we've just taken that piece out.
It's actually like the way, if I had a grandfather who was a physician, that might have been how it would have been practiced. Would have made a visit to your home, you might have made a visit to his home, which the parlor or the living room was actually where he or she practiced. It was almost always going to be he in those days. There would have been an exchange of something of value. There wasn't an insurance company. There wasn't a collection agency in between. That was how care was delivered. It was relational, if you will. Well, that's certainly not where we are today. And in those days, by the way, who owned the physician's practice? The physician owned the practice and owned his parlor or whatever. And, somewhere between, probably around 2006 or so, we went over the halfway mark of most physicians working for someone else. That someone else is more likely than not to be a hospital or a healthcare organization. Those healthcare organizations get their money through panels of covered lives. Those covered lives belong to or are under the auspices of an insurance company. Direct primary care says, wait, time out. This isn't working. What if we go back to that relational basis for delivering care? If you pay us monthly, $100, we'll provide to you the following services when you need them. In many states, that's required to be dealt with by an approved insurance product. And so what the legislature is dealing with now is saying, wait a minute, time out. This direct primary care, it's not insurance. We are condoning this and supporting it and actually would like to incentivize it because it's a much less expensive model.
The end goal is to help your patients and to keep them healthy, but there are so many other parts of that. It's running the business, it's doing the paperwork, it's getting reimbursed, it's taking people's insurance, it's, everything that happens. It's parents getting mad at you because their child's not better. When you're young and you're idolizing medicine and then you get into the everyday work, it's still a job. It's a service, but there are also aspects that are still a job. And I think that to certain people, that wears on them. They feel like they want to get to the days where they can just do what they want to do for the patient to make them better and not have to justify it through paperwork or justify it through insurance companies to get this medication for their patient.
By April or so of 2017, this piece of land, the old Florida Highway Patrol buildings, is looking better and better. It addressed the critical factors that we wanted. Among them, one is we wanted to be in a community, part of a community. We wanted to be neighbors with. We wanted to engage in the health needs of an underserved community. Number two is it was on some major bus lines. There's a major east-west bus line that Star Metro runs across, stops right across the street. It was right across the street from an elementary school that was serving a very underserved population. Over 90% of the kids there qualify for a free lunch. So at that point, one of our first stops was with a woman by the name of Anisha Robinson. Ms. Anisha Robinson is the principal of Sable Palm Elementary. And we said, what do you think? What do you think about this piece of land? She was over the top thrilled with this. Great, absolutely, we need this in the area. Shockingly, one of the common problems that they have there is kids who can't start school, sometimes for weeks from when they should be able to start. Because in Florida, as in most states, you cannot start school until you get a physical exam. A doctor has to certify that you're healthy and ready to start school. Makes sense. We don't want to send kids to school who've got an active case of tuberculosis or chickenpox. So they would have kids who moved to this area, from Georgia, right across the state line. And a parent would say, I'm trying to register my child for school. They said, kid can't start until they get a physical. And it would sometimes be 6 or 8 weeks when that third grader sits at home, cannot start school because they can't get them in to get a physical. And whether it's because they weren't available at times that were convenient to the parent didn't know where to go, the parent didn't have insurance to be able to cover this. So that was one of the very first promises that I made. I said, if we get this up and going, any kid who can't start school, you give us a call, we will offer them an appointment within 24 hours. From that, we said, now we got to start talking to the community. That's what we need to do. We need to talk to the people who live here. What would they think? So we held a community meeting, started getting some positive feedback. We did door-to-door surveys, asking people, what do you think about a clinic in this area? Had some group meetings with a number of people in leadership. So the leadership of some of the homeowners associations down the Providence neighborhood and other places, talked to some of the pastors of the churches, that sort of a thing. Response overwhelmingly positive. I mean, absolutely overwhelmingly positive. We said, this is what we need. We don't have anything else like this in the neighborhood. This would mean so much to me, so much to my family, so much to others to be able to have this access to care, to have it right here in our neighborhood, et cetera, et cetera. The place across from Sable Palms allows us to put in a modular facility that we'll be able to have up and running over a period of 6 months rather than the years it would take to do fundraising, put in a permanent structure. While that modular facility is in place, if we are as successful as we believe we will be, over a period of 5 years or so, we could have a permanent, much bigger structure offering many more services, much more interdisciplinary teaching and research on that same piece of property. And we wouldn't have to close our doors. We can build it on the other 2 acres that sit behind us.
I think that it could present an opportunity for us to have an astounding multidisciplinary environment to do what it is we really have always wanted to do. Primary care is not about one person, and I think the physicians would acknowledge this. It's not about one physician. It's really about a team working to provide for the whole person needs of an individual. That's especially true as we age. It's also especially true for children and families. When you're treating an individual, particularly a pediatric patient, you're obviously not treating just that individual. If you're treating an adult from a family medicine perspective, you really need to be engaged with the entire family, particularly in situations where there might be an economic disadvantage or where there may be issues in the person's home environment that are impacting their healthcare needs. And what I would envision as well is a multidisciplinary center, a number of us that are working together to provide a center for primary care that would be much broader than just a medical clinic.
I would say that having integrated care also improves access to care. So we know that there's a shortage of primary care physicians in general. When you bring in a different discipline like psychology, physicians can focus on what they do best, and a psychologist can take over whenever there's a behavior component. So whereas before integrated care, a physician would really have to do it all. And so that would take time away from the physician to be able to go on and see another patient. So now what the psychologist can do is save the physician quite a bit of time that then they can use to see another patient. So we're improving access by allowing that physician to see a greater number of patients, given that now there's a different specialty within that same setting that can take over the behavior component.
So right now, we are in the process of finalizing the purchase of just 1 acre of land. So FSU owns 3 acres with kind of a little bit of 1 acre bite out of it. We want that other acre of land, so we've got a 4 acre rectangle. That land completion, we should have that title in our hands within a couple of weeks. We also have, as of now, developed the floor plan for how we want this clinic to work, looking at having about 16 exam rooms, a couple of procedure rooms, the ability to be able to have 6 or 7 clinicians working at any given time. We can be open for business in July or August of 2018. The 1-2 year goals are to be at the break-even point. We know that the first year, during that first year, we will be in the red because of how much it takes to get this thing off of the ground. It is our hope and our projection that by the 4th quarter, the 4th financial quarter, that's the time that we'll turn the corner and start to be in the black and the break-even point. I mean, our goal, again, for this that I think is critically important, that separates us from most medical schools, is we're looking for this to be a break-even proposition. not to be a major funding stream that funds other activities of the College of Medicine. Most medical schools, that's what it is. The practice is a revenue river, okay? We're looking just to keep a little bit of a creek bed running so that we don't bleed dry, because if we don't have any margin at all, we can't continue to lose money on this year after year after year. My hope, my aspiration is that we are so successful in meeting our numbers of patients seen and staying in the black, et cetera, that we are able to actively gain outside financial support. Our 5 to 10 year dream is that in that 5 to 10 year window, we have a permanent bricks and mortar, perhaps 3-story, 60,000 square foot facility for which FSU Primary Health occupies 1 floor of it.
I chose to stay in primary care. I'd always wanted to do primary care and knew that coming into medical school. I love teaching, and I really love not just dealing with patients when they're really sick, but I like taking care of them to help prevent problems and hopefully keep them out of the hospital as much as possible. And I think there is a blessing in carrying the title of physician. Patients listen and open up to you in a way that your neighbor is not going to get the same openness when you talk to them. And so I think there's an inherent trust that is built into being a physician. And so I wanted to be that teacher, but I also loved the science and the puzzles behind each patient's condition, but really loved talking to them.
I realized going to 4th year that I was really missing that research component that I was interested in while I was an undergrad. So that's how I first started thinking, wait a second, what exactly do I want to do? What is my scope of my job going to look like if I go into a primary care field or if I'm going into something that's a more academic field?
So how we think about now health and prevention and primary care and insurance and all that has to include the fact that now health is not just about one physician and one patient. It's about a team effort.
I think when we get into these debates about healthcare reform, we forget the simple facts. I mean, we need to ask ourselves what works, what does the evidence show is effective, and how do we do that? You know, the evidence should really guide the policy.
It's a tough hill to climb, but the notion that somebody else needs to fix it, I don't think that's helpful. I think that each of us need to be responsible for our own behavior and how we seek health, how we take care of ourselves. I think that each of us needs to look a little bit outside of ourselves as well to our neighbor and see what's fair.
Nobody wants to be unhealthy, but if you don't have those tools to make good health decisions because you don't know any better, then you won't get any better.
I think the biggest misconception in this whole debate is that there is one single answer. You know, what I get most frustrated about is our inability to listen to the multiple perspectives. You know, there is no way through any conversation when we are not able to listen to multiple perspectives.
We made the decision as a society hundreds of years ago that it was in our interest as a country and as a society to be successful, that we should educate all of our citizens. We have decided that it is good to have safety in terms of police force and a firehouse. That's what we have agreed to. We haven't done that with health. We haven't said it's good for our society to have our citizens who are basically healthy. Not everybody is going to get a free kidney transplant when they're 95 years old. You draw a line somewhere, just like everybody doesn't have a fireman and a policeman parked in front of my house 24/7. That's ridiculous. But we say we meet those general needs. That's the way we need to approach healthcare. It's good for our society.